So if you break your arm, the X-ray is entirely binary, right?
Yeah, exactly. It's just black and white.
Right. I mean, the jagged white line is there or it isn't.
Yeah.
The doctor points to the screen, slacks a cast on it, and you go home.
Hmm.
And it's comforting. We like things to be visible and easily categorized, but what happens when the battleground is actually the inside of your own mouth?
Well, that's when things get complicated.
Yeah, you step into this world of mucosal health and immunology, and suddenly that diagnostic X-ray machine is just, well, it's completely broken.
Oh, absolutely.
We are looking at a landscape that is murky, complex, and, driven by this rogue immune response that leaves behind these delicate white spider webs or painful ulcers or even scar-like plaques.
It is the absolute definition of diagnostic muddy waters, I mean, truly.
Right.
The oral cavity is this incredibly sensitive ecosystem, and when the body's internal wires get crossed, the visual evidence it leaves behind can be, well, it can be baffling even to seasoned clinicians.
Totally. And today's mission for this deep dive is all about exploring that mysterious ecosystem.
Yes, a very deep dive today.
We are zeroing in on two oral conditions that they sound almost identical, but operate in vastly different ways.
And they really do.
Right, so we're looking at oral lichen planus, which we'll call OLP, and oral lichen sclerosus, or OLS.
It's a bit of a tongue twister.
It really is. To decode these medical tongue twisters, our stack of sources is, it's pretty robust today.
We've got a lot to get through.
We really do. We are pulling from clinical guidelines from the British Association of Dermatologists, the British and Irish Society for Oral Medicine, plus several fascinating medical journal case reports and some NHS patient leaflets, too.
And I have to say, those sources give us a beautifully complete picture.
Yeah, they really cover all the bases.
Exactly. I mean, we have the clinical data, the microscopic pathology of what the cells are actually doing, and crucially, the day-to-day reality of the patients living with these conditions.
Okay, let's unpack this. Our goal here is to give you, the listener, a shortcut to being well-informed.
Right.
By the end of this deep dive, you will know how to spot the differences between these two conditions, understand the underlying risks they carry, and most importantly, know what it all actually means for your own oral health.
Which is the most important part, really.
Exactly. So we are going to start with the heavyweight of the two, OLP.
The big one.
Yeah, statistically speaking, you or someone you know is actually quite likely to encounter this in the real world.
The prevalence is really what makes it a heavyweight. I mean, the clinical guidelines note that oral lichen planus affects roughly 1 to 2% of the general population.
Which is huge.
It is. That represents millions of people. It typically presents in middle-aged adults, and it is slightly more common in women.
Okay, so it's not super rare.
Not at all. At a biological level, OLP is a chronic T-cell-mediated autoimmune inflammatory disorder.
And I found the mechanics of this so fascinating in the literature. It's almost like the body's immune system is this confused security guard.
That is a great way to put it.
Right. The T cells are aggressively attacking the inner lining of the mouth as if it's a foreign invader. They specifically target the stratified squamous epithelia.
Which is basically the delicate skin inside your cheeks and on your tongue.
Exactly, just attacking it for no reason.
And that confused security guard analogy, it captures the pathology perfectly. Because for reasons the medical community still doesn't entirely understand, those T cells just go completely rogue.
They just flip a switch.
Basically, yeah. And when they mount that attack on the mucosal lining, they leave highly specific visual evidence behind. The most common presentation is the reticular pattern.
Right, the reticular pattern.
Yeah, so if you look inside the cheeks of a patient with this, you see a painless, white, lace-like network of lines. Clinically, this is known as Wickham striae.
Wickham striae. I mean, looking at the pictures, it looks like a delicate, intricate white spider web just painted directly onto the inside of the cheek.
It's very visually striking.
But the sources point out that this spider web is just the mildest manifestation, right?
Oh, far from the only one, yeah. The inflamed tissue can actually take a papular form, which appears as these small, raised white dots.
Oh.
Or it
yeah.
could be a plaque-like form, showing up as homogeneous, thick white areas. And interestingly, the British and Irish Society for Oral Medicine notes that this plaque-like presentation is particularly common in patients who smoke.
Wow, okay.
Yeah, or in some cases, patients with a hepatitis C infection.
But those forms, like the webs, the dots, the plaques, they're mostly painless, right?
Generally speaking, yes.
So the confused security guards are doing some damage, causing this hyperkeratinization, but it's not necessarily causing a 5-alarm fire for the patient's daily life.
Right. It's manageable. But the severe forms are where the daily reality becomes just grueling.
Yeah, I was reading about that.
It's rough. A trophic OLP leaves behind these raw, red, sore areas.
Ouch.
And then there is the erosive or ulcerative OLP, which results in frank, highly painful ulcers. And even bullous OLP, which actually causes fluid-filled blisters inside the mouth.
I can't even imagine. And reading about how this affects the gums was just brutal.
Oh, the desquamative gingivitis.
Yes. The clinical term in the source is the gums literally peel.
It's awful.
They become incredibly red, shiny, and so tender that basic functions like just eating or brushing your teeth become an agonizing chore.
Yeah, it really impacts quality of life. But what's fascinating here is that while OLP is a primary autoimmune issue, meaning the body's attacking itself for no external reason, it can actually be perfectly mimicked by outside invaders.
Okay, wait, explain that.
Well, the dental and medical fields call these fake-outs lichenoid reactions.
Lichenoid reactions. I really wanted to dig into the mechanism of these fake-outs because structurally and visually, a lichenoid reaction looks exactly like OLP, right?
Indistinguishable to the naked eye, yeah.
Yeah, but instead of an unknown autoimmune trigger, it's a localized hypersensitivity reaction triggered by everyday things, including, like, very common daily medications.
The list of pharmaceutical triggers is extensive, honestly. We are talking about common blood pressure medications, specifically beta blockers and ACE inhibitors.
Which so many people take.
Exactly. Non-steroidal anti-inflammatory drugs,
Oh.
so NSAIDs. Even oral anti-diabetic medications can trigger it.
When you think about the causality there, it's just wild. You swallow a pill for your heart or your blood pressure, and as your body metabolizes that medication, certain compounds end up secreted in your saliva. And for the vast majority of people, it's completely harmless. But in some individuals, the oral tissues become violently hypersensitive to those specific molecules in the saliva, right?
Exactly. It triggers a localized allergic immune strike that leaves a web of white lines on the cheeks.
It really highlights how systemic everything is.
Oh, for sure. And it's not exclusively systemic medications either. You can have a localized contact reaction to dental materials.
Oh, right, the fillings.
Yeah, the classic example documented in the case reports is a reaction to metal dental amalgam fillings. A patient will develop a persistent white patch or an ulcer directly adjacent to one specific silver filling.
Just one filling. The body just decides, perhaps years after the filling was placed, that it absolutely hates that specific alloy.
It just rejects it, yeah.
It mounts a hyperlocalized immune response just millimeters away from the tooth.
And in those specific lichenoid cases, simply replacing the metal filling with a composite or maybe changing the blood pressure medication under a cardiologist's supervision can resolve the lesions entirely.
That's incredible.
Yeah, the trigger is removed, the T cells stand down, and the mouth just heals.
So we've got this scenario where a common blood pressure pill can trigger a massive web of visible tracts in the mouth.
Right.
But our sources spend an incredible amount of ink fixating on a condition that does the complete opposite. A condition so incredibly rare in the oral cavity that almost nobody gets it.
Ah, yes.
I'm talking about oral lichen sclerosus, or OLS.
If OLP is the common heavyweight, OLS is the elusive unicorn of oral medicine.
The unicorn, yeah.
To understand how rare it is, we really have to look at where lichen sclerosus typically operates. About 85% of all LS cases occur in the anogenital area. You occasionally see extragenital LS on the trunk or the extremities, but manifesting inside the mouth, it's an extremely rare subtype.
The review in our stack of medical journal case reports actually counted them. There have only been 39 biopsy-confirmed cases of oral LS reported in the global medical literature since 1955.
39 cases in over half a century. You are looking at a true statistical anomaly.
It's almost non-existent.
Pretty much. And clinically, it behaves very differently from its cousin OLP. You don't see those lacy webs or red peeling gums. Oral LS typically appears as an asymptomatic, whitish, firm, sclerotic plaque.
A localized area of fibrosis, essentially a patch of thickened scar tissue.
Yes.
And over half of these rare 39 occurrences are found in one highly specific anatomical spot, right? The labial mucosa, the inner lips.
The inner lips, exactly. The case study of the 58-year-old female patient in our sources paints a perfect picture of this.
Yeah, I remember that one.
She was referred to a specialist by an ear, nose, and throat doctor for a lesion on her lower lip. She presented with a 1.5 centimeter, well-defined, firm, whitish plaque, and she had noticed it a full year prior.
Now, here's where it gets really interesting, because I have to push back on the clinical necessity here.
Okay, lay it on me.
You have a patient with a condition so vanishingly rare that only a few dozen people have ever had it in modern medical history.
Right.
It's a tiny, firm, white spot on her lip. It's completely asymptomatic. I mean, no burning, no pain, no trouble eating. Why go through the invasive trouble of diagnosing it? Why poke the bear if the bear isn't bothering you?
That is a very fair question.
Hmm.
But the clinical urgency isn't about what the plaque is doing at that exact moment. It's about what the plaque might be.
Huh.
Diagnosing oral LS accurately is crucial because a firm white patch on the lip mimics a whole host of potentially serious conditions. In oral medicine, a white plaque is guilty until proven innocent.
Guilty until proven innocent. Because it could be leukoplakia.
Exactly that. Leukoplakia is a known precancerous lesion.
Wow. Okay.
A doctor cannot look at a white patch and simply guess that it's the harmless, rare unicorn of oral LS. They also have to rule out things like vitiligo, which causes depigmentation, or morphea, which is a localized form of scleroderma causing hardened skin.
Right. And the cancer risk data between the different forms of lichen sclerosus is pretty fascinating, too.
It really is.
Because genital lichen sclerosus carries a well-documented risk of transforming into squamous cell carcinoma, right? Somewhere between 0.4 and 6%.
Yes, but malignant change has never been documented in a single reported case of oral lichen sclerosus.
Wait, really? Never.
Never. The location entirely dictates the cancer risk. The genital mucosa, under the stress of LS, has a malignant pathway, while the oral mucosa, under the exact same disease process, has a 0% cancer risk.
That is just wild to think about. But of course, the clinician doesn't know they're dealing with the zero-risk oral LS until they actually test it.
Exactly.
Which brings us to the diagnostic showdown. To the naked eye, a white patch from OLP and a white plaque from OLS look remarkably similar. The forensic tiebreaker here is a minor surgical procedure, a biopsy under local anesthetic.
A biopsy is the only way to know for sure.
Right.
A pathologist takes a tiny tissue sample, places it under a microscope, and looks at the actual cellular architecture.
Right.
So while the naked eye sees a generic white spot, histology reveals two completely different microscopic footprints.
Looking at the pathology notes from the sources, the early stages of both actually look identical, just this massive swarm of T cells infiltrating the tissue. But as the disease progresses, their paths violently diverge. Let's talk about the OLS footprint first. The literature describes something called hydropic degeneration.
Right, hydropic degeneration.
Right.
That term sounds intimidating, but the mechanics are fairly straightforward. The basal cells, which are the foundational layer of the skin, they essentially give up.
They just quit.
Yeah, they swell with fluid, or water, which is the hydropic part, and they degenerate. Beneath that failing layer of cells, the underlying collagen undergoes a massive structural change.
The collagen becomes homogenized, right?
Yes, exactly. Normal collagen has a stretchy, woven, basket-like structure.
Okay.
But in OLS, it loses that weave and basically fuses into a thick, uniform band of hyalinized scar tissue.
And that biological fusion is exactly why the OLS plaque feels firm and sclerotic to the patient's touch.
You hit the nail on the head.
It's essentially a dense knot of scar tissue.
Now compare that to the footprint of the heavyweight OLP. The T cells in OLP mount a much more aggressive destructive campaign.
Yeah.
The boundary between the outer layer of skin and the tissue below it becomes wildly irregular. The pathologists in our sources actually describe the tissue border as having saw-toothed ridges.
Sawtooth. So the tissue literally looks like the edge of a serrated knife.
Yes, exactly like that.
And the sources also highlight the presence of CVOT bodies in the OLP biopsy.
Mm-hmm.
If I'm understanding the biology correctly, the T cells are attacking the skin cells, the keratinocytes, forcing them to commit cellular suicide, which is a process called apoptosis.
Right, apoptosis.
So the CVOT bodies are quite literally the microscopic corpses of dead skin cells just littering the tissue.
That is precisely the mechanism, yeah.
Mhm.
It's a microscopic battlefield. So the pathologist looks through the lens. If they see a thick, homogenized band of scar tissue from fluid swelling, they diagnose the rare, harmless oral LS.
Okay.
But if they see a serrated sawtooth border littered with the corpses of apoptotic cells, they diagnose OLP.
And this raises an important question about the long-term stakes here.
It really does.
Because we established that oral LS has a 0% chance of turning into cancer, what are the stakes for the patient whose biopsy comes back showing that serrated OLP footprint?
Well, the stakes shift considerably. Unlike OLS, oral lichen planus has a documented malignant potential.
Right.
The clinical guidelines place the risk of OLP transforming into oral squamous cell carcinoma at roughly 1% over a 10-year period.
A 1% risk over 10 years is relatively low, but it completely changes the patient protocol, doesn't it?
Oh, absolutely. It transforms the condition from a temporary nuisance into a lifelong relationship with an oral specialist.
Wow.
A patient with OLP requires consistent, long-term monitoring. The dermatological and dental guidelines actually mandate that specialists look for specific red flags during follow-ups.
What kind of red flags?
If an isolated area of whiteness starts rapidly increasing, or if they see speckling, which is a mix of red and white patches, or a solitary ulcer that refuses to heal, it requires immediate surgical review.
So what does this all mean? We've covered the immune mechanics, the rare statistics, and the microscopic cell corpses. For the listener out there navigating mystery mouth pain or maybe a fresh diagnosis, how do we actually tame these conditions?
Well, the fundamental truth of both OLP and OLS is that neither is strictly curable.
Okay.
You cannot take a 2-week course of antibiotics and just banish the rogue T cells forever.
Uh-huh.
However, they are highly manageable.
That's good news, at least.
Yeah, and both frequently go into spontaneous remission, though OLP can stubbornly persist for years. But the entire management strategy is dictated by the patient's symptoms.
Right, and the British guidelines emphasize a very pragmatic approach for mild asymptomatic cases.
It's very pragmatic.
If a patient has the rare OLS plaque or the lacy reticular spider webs of OLP and they feel absolutely no pain, the recommended medical intervention is to do absolutely nothing.
Exactly. First, do no harm. There is just no justification for exposing a patient to strong medications if their immune system is only painting a painless white web on their cheek.
That makes total sense.
But when the condition shifts to erosive OLP and the patient's mouth feels like it's on fire, we step in to aggressively dampen that localized immune response.
And the mainstay of that treatment involves topical corticosteroids, right?
Yes, topical steroids are the first line of defense.
But you can't just rub a standard steroid cream inside a wet environment like the mouth. The saliva would just wash it away in seconds.
You're exactly right. The pharmacology has adapted to the environment. Patients use specialized steroid mouthwashes or adhesive pastes that actually stick to the wet mucosa.
Oh, wow.
Yeah, or aerosol sprays or even small pellets that dissolve directly against the ulcer. And if the topical steroids fail to calm the aggressive T cells, specialists escalate the treatment.
What's the next step?
They might prescribe systemic immunosuppressants taken as a pill, like azathioprine.
Or topical calcineurin inhibitors like tacrolimus, which basically act as a localized mute button for the immune system.
Exactly. A mute button is a great way to describe it. And looking back at the 58-year-old woman with the oral LS plaque, her firm scar tissue actually resolved beautifully after her doctor used a combination of topical steroids and an intralesional injection.
Oh, a steroid shot delivered directly into the plaque itself.
Directly into it, yes.
Yeah.
But beyond the prescriptions, the medical guidelines focus heavily on the patient's daily habits because the oral ecosystem is incredibly reactive to external stressors.
And the actionable advice in the NHS leaflets is just incredibly empathetic to the pain these patients are in. First up is diet.
Diet is huge.
If your gums are peeling and raw, the mechanical and chemical trauma of eating spicy, highly acidic, or salty foods is going to trigger immense pain. A splash of citrus basically becomes a localized torture device.
It really does. And then there's the brutal catch-22 of oral hygiene.
Right.
When a patient has desquamative gingivitis, brushing their teeth feels like dragging sandpaper across an open wound.
Which sounds horrific.
It is. So the natural human instinct is to just stop brushing.
But the sources stress that stopping is the absolute worst thing a patient can do.
The absolute worst.
If you stop brushing, bacterial plaque rapidly accumulates on the teeth and the gum line. That bacteria acts as a massive secondary irritant, triggering even more inflammation and creating a vicious, agonizing cycle.
Exactly. To break that cycle, patients are advised to use an ultra-soft toothbrush and gentle interdental brushes. And crucially, they need to audit their toothpaste.
Yes, the toothpaste audit. The NHS specifically recommends switching to a toothpaste free from sodium lauryl sulfate, or SLS.
Which is so important.
SLS is the chemical foaming agent in almost all commercial toothpaste. It's what gives you that satisfying mouthful of suds, but it is also a known chemical irritant.
It really is.
The NHS leaflet actually highlights a specific brand, Kingfisher Mint toothpaste with fluoride, because removing that harsh foaming agent from an already stripped, fragile mucosa makes a world of difference for OLP patients.
It can be a game changer. Finally, there's the non-negotiable advice regarding the 1% cancer risk. Patients must stop smoking and strictly limit alcohol consumption.
No exceptions there.
None. Smoking and heavy alcohol use are the primary independent chemical drivers of oral squamous cell carcinoma. If your immune system is already laying the groundwork for cellular damage with OLP, introducing tobacco smoke is essentially pouring gasoline on a smoldering fire.
If we connect this to the bigger picture, diving through these guidelines and pathology reports really highlights a profound reality about the human body.
It really does.
The mouth operates as this incredibly sensitive immune system dashboard. It is a highly vascular reactive mirror where pharmaceutical side effects, systemic stress, and autoimmune glitches show up as visible physical alerts long before you might feel them anywhere else in the body.
It completely strips away the illusion that the mouth exists in a vacuum, separate from the rest of our medical health. The ecosystem of the oral cavity is intimately bound to the medications you swallow, the stress you carry, and the complex genetic instructions guiding your immune system.
That wraps up our deep dive into the microscopic battles happening right behind our teeth. We've navigated the surprisingly common serrated footprints of oral lichen planus and the elusive homogenized scar tissue of oral lichen sclerosus. We really hope this exploration has given you a vivid shortcut to understanding the complex mechanics of mucosal health, the vital importance of the biopsy, and how to protect your own oral ecosystem.
And before you go, I want to leave you with a thought that constantly surfaces when reviewing these immunological cases.
Oh, definitely.
Consider the sheer baffling mystery of the immune system's targeting system. Why does a systemic malfunction of the T cells decide to wage a hyper-focused war exclusively on the inside of the cheeks? Or, in the case of our 58-year-old patient, why does the immune system select one single 1.5 centimeter spot on the lower lip to attack, while leaving the entire rest of the body completely untouched?
So weird.
It points to the existence of hidden, highly localized microenvironments within our own bodies, invisible biochemical boundaries that we have yet to fully comprehend. The diagnostic X-ray machine might be broken here, but the murky waters of the immune system are teeming with secrets waiting to be mapped.
A perfectly fascinating thought to leave us with. Keep exploring and keep diving deep.